Thank you for the presentation, Lady, and we will start from the beginning. Okay, so here's the presentation. The topics will include what is a success, about our randomized clinical trials, pre-randomized clinical trials, multi-center studies, about the objective measurement. Is it better than placebo? Is having any effect on PD5 non-responders? How long does it last? Additional treatment to improve results if it's having any success. I will talk later about the sixth treatment protocol, post-radical prostatectomy patient, different devices and different protocol, and what is the protection pension for ED treatment and how we get around 68-70% success rate. So what's the conceptual limitation of normal other therapies for ED? One is they are all on demand. Secondly, there are lack of spontaneously. They are totally dependent on therapy. They are only a treatment of the symptom they are not curing one, and limited effectiveness. They are only about 50% responders are not fully satisfied with the normal PD5 and other therapies, and 50% we all know from literature they are discontinued from the treatment. So actually we need to have some other treatment that will treat the current treatment of sexual dysfunction, and that will be last-line. Shockwave, as a physiology, you see here at the cartoon, is having a short, high peak of pressure, and then small waves of intensity. It starts with the 1987, during the 70s of the last century with lithotripsy, and then they moved to orthopedics and wound healing and diabetic. And around 2000, they start to treat cardiology. And at that point, we found out that something happened with vascularity. And in 2010, we start to publish some article that we investigate during the 2007, 2008, and lately they start with the kidney system. Treatment protocol was based on our during our studies about 3 weeks of twice a week treatment protocol in six session, 3 weeks of interval, and another 3 weeks of 6 treatment twice a week in a total 12 treatment. It was a 5 treatment area along the corpora, 3 along the penis, and others 2 at the corpora cavernosa. 300 shocks per each area, 0.09 millimeters per millimeter each area. It's 1,500 shocks per treatment, and 18,000 as a total. The treatment is about 15-20 minutes, including undressing and gel pollution, cleaning the gel treatment, and so on. It's about half an hour, about 15 minutes, half an hour treatment in a whole. This is the machine. This is the ED1000. It's easy to control, easy to handle. The probe is very light. The session is easy to handle, and for the 12, 13 years, last 12, 13 years, we don't have any problem with the machine. The probe is rechargeable, and you can use it in a private clinic. It's very small and very comfortable. I would like to Start with the idea, what is a success about erectile dysfunction treatment? Irving Goldstein in 1998 was inventing the EHS, the erection hardness score, which means that if you have a level of 4, meaning your panel is fully erection and fully rigid. If it's 3, it's not fully rigid, but still you can penetrate. And 0, 1, and 2, it's the penis is not rigid enough to have a full, complete sexual intercourse. And in Ray Rosen in 1997, 1 year before the Viagra area, invented or published the IIF-ED domain. It's a 6 questionnaire, 5 points for each one, means that 25 and above is normal, around from 19 or 20 to 24 is mild, mild to moderate, moderate and severe. And from that time, it was very easy to define what is success. If its IIF is over 5, it was at that time, and if it's EHS about 3 and 4, meaning that sexual intercourse is feasible and it's possible, and that means success. In 2011, Ray Rosen again wrote down in article about the MCID, the minimal clinical import of difference, and he said that 5 points of IIF-EF is not enough. If you are severe, you need to have 7 points. If it's moderate, 5 is okay, and if it's mild or mild to moderate, you have to increase in at least 2 points. And from now on, our investigation, our randomized blind trial, and all over the world, the significance of MCID is the improve of change and a significant difference statistically. We took all our randomized clinical trial, a little bit over 280 patients. It's 95 from US, 30 patients from Greece, 77 from our group in Israel, and 80 patients from India. And you see here that the midterm after the interval of the 6 treatment, they are all around 4.5 IIF domain. After 1 month following the treatment, the whole 12 session, it became 7.4, and there is a little decline for 6 months and 12 months, as you see. But if you divide it to the mild and moderate and severe, you see the difference. I published it in having a discussion at the AUA in New Orleans in 2017. And if you're looking at the MCID of new Ray Rosen criteria, you see that the mild treatment, the mid treatment of the total, it was 56.4% success. 1 month was 66, and if you see if the total, it's over 75%, which means there are different statistically different change in erectile dysfunction with or after, especially after the treatment. We are talking about 12 session treatment. What's the objective measure? The questionnaire is subjective, and we would like to have some objective measurement. And the first one is NPT, the rigid scan, which all of us are not satisfied with that. So in 2006, Professor Vardi and I was published in Journal of Urology, the FMD, the flow mediated dilatation test, which is a technique which do ischemic treatment for between 2 and 5 minutes, and we measured the endothelial function before as a baseline and after the ischemic. As you see here, it's coming from circulation of autonomy distribution, and we published it, and it was accepted by the American Urology Association as an objective test. And I emphasize that this test is non-invasive, it's easy to perform. As you see here, this is the penis. It's the strain gauge that you put on the penis on the arm. I measured the systemic endothelial function and the penile endothelial function. That's a Hawkinson American system machinery, and you see here the example of treatment, a patient before the treatment. You see the area under the curve is low, and it's post-ischemic. And you see the post treatment is totally different, which means it's an improved. This is the area under the curve. It's a millimeter to minute, deciliter of tissue, and you see that the calculation, the area under the curve is the measurement of the ischemic flow assessment of the penis, as well as the systemic on the arm. Did it to compare the systemic and the penile endothelial function. Here you see the change in the maximum penile flow between the patient that we treated and the sham or placebo. You see the difference, that the endothelial function is totally different. We keep the endothelial function in correlation with the IIEF, you see that the baseline there is a correlation between the FMD, the flow mediated dilatation test, and the IIF along the baseline flow and the maximum flow. Professor Christo in Greece, part of the multi-center, did it on 46 patients, and he used the normal Doppler ultrasound. It's an invasive system because you have to inject vasodilatation substance. He took his 30 patient treated group and the 16 placebo, sham control. They are all around 50, about 50 years old. The mean ED was over 5.5 years, and half of them were cardiovascular, and 1/3 were diabetic. And again, you see that the midterm was 40% on the treated group and 12.5% at the placebo. 1 month it was higher, and 3 months later it was 46.7%, according to MCID patient. And he presented it in Copenhagen during the 17th Congress of the ESSM. In this slide, you see that the difference between the sham group and the active. You see that the Doppler ultrasound is getting better in those who are active active patient, and he did it the same as we did with the FMD. The correlation between the ultrasound and the IIF, you see the difference that all the plot here is about 35 patients that they are really having a good success. Lately, the couple from the Lerman couple from Mayo Clinic was having the same result on atherosclerotic renal artery stenosis. This is a normal flow of the kidney. This is the flow in atherosclerotic renal artery stenosis patient, and this is how it became better after treatment shockwave. They did it on animal, on pigs, and they gained a lot of publication on that. So now it's the question: is it better than placebo? So we published it in 2010. I took 77 patients. I screened them. I randomized to 1 to 2. 21 patients got Sham, and 46 got real treatment. And in a total, there was two-thirds of the patient got the treatment, and 1/3 got the Sham. The protocol was this protocol. The patient were responders to PD5. I washed them out for 1 month from the PD5 treatment. I divided it to two group treatment and sham control. I gave them 3 weeks of treatment, twice a week, total six treatment, 3 weeks of interval, and another 3 weeks of treatment, in total 12. I was waiting 1 month, and I post-treatment follow-up 1. I assessed all the patients before and after the treatment. The patient characteristic was in both groups was quite the same. Age was similar. Duration of ED was a little bit longer in Sham, but not significantly statistic. Cardiovascular patient, coronary artery, diabetics. ED IAF domain was almost the same. I divided them in severe, moderate, mild to moderate, and mild patient. And see here the placebo, the sham control patient was not improved, while those who got the treatment was improved from 12.7 to 19.4, which is which in both MCID or IAF EF domain, it was improved. Actually, there was around 65, 68 patients were responders were have improved after the treatment, as you see here, the treated group and the placebo group. And according to EHS, the rectal hardness score, it was the same result. The sham group was almost similar. The treated group was improved very much. The point is, I'm showing here that those who were placebo, according to our Rambam Helsinki committee, they order me to give the patient who were placebo at least a full real treatment of the shockwave. So I put it here in this cartoon. After the post treatment of the sham, there was no change. When I gave them the real treatment, they were improved as well as those of the treated group. So it means that actually there is no placebo effect during these 13, 14 weeks of treatment. The next question is there any effect on PD5 non-responders to PD5? So my next group was non-responders to PD5. I screened them after one month of treatment of PD5. They came back to my clinic and said, your PD5 inhibitors was the same, was having the same result as before. No result. I told them, okay, if it doesn't work, don't take it. And I gave them the same protocol: 3 weeks of treatment, 3 weeks of interval, and another 3 weeks of treatment. I was waiting 1 month without treatment, and this was follow-up 1. And for the next one, for the next follow-up 2, I gave them the same PD5 inhibitor that was not working at the beginning after the screening. And the patient were 33 patient non-responders to PD5. 4 were discontinued, were screen failure or dropouts, and I finished with 29, less than 10% of the patient after the 12th session, and that's the result. Visit 1, I remember, I'm recalling you that it's without PD5 inhibitors. 1 month later, follow-up 2 was with PD5 after 12 session of Shockwave, and it's about 22 out of the 29, 75, almost 76% were successful, and with significant statistically significant improved, which is a p-value less than 0.001. And here you can see at visit 1, none of them were responders. After the follow-up, after only 12 sessions of Shockwave, 1/3 were improved, and 1 month later, with the PD5 in follow-up 2, 21 out of those 29 patients were able to penetrate and to perform full intercourse, and which means they were successful. Our clinical experience was published in those 3 journals in different times in randomized clinical trial. And the last question, because usually when patient is coming to me, is asking if the Shockwave is successful, how much it costs, and the third question is for how long does it last. So I took those 72 patients, all 72 patients who were considered successful at follow-up 1 month after the post-treatment from those 3 randomized clinical trials, and I followed them for 2 years. The median age was around 60 years. The baseline, you see, 23% were mild, 44 were moderate, and 1/3 were severe. There were responders to PD5 in 77%. There are cardiovascular risk factor patients, cardiovascular disease patients. 1/3 were diabetic, and I followed them after the follow-up 1 and follow-up 2. I follow up them at 6, 12, 18, and 25 months, 2 years, almost over two years. And this is the result of the 72 patients, 2 years, who were successful after the first session of the Shockwave treatment. Okay, so 1 month, it's 100%. You see 3 months, 6 months, 1 year, 1.5 years, and 2 years. Means that almost 60% of those who were successful after the first treatment were still satisfied after 2 years. So I can say that at least almost 60% of them were successful after 2 years. This is the Kaplan-Meier of the degradation of the patient along the period. And multivariant analysis, only severity and diabetics are having a good influence of the successful after 2 years. Means that the most severe patient is getting less and less as more they are severe, and the hemoglobin A1C, the higher is the worse for having a longer result, while all the others, the age, cardiovascular risk factor, cardiovascular disease, and responders or non-responders to PD5, is having very very low effect on long effect of the treatment. So I can say that the age and severity is the most important factor influence a long result. The next question is, can additional session of shockwave therapy improve the results of the patient that were failed? Because I did the randomized clinical trial, again, the Helsinki, I mentioned that the Helsinki committee ordered me to give them a real treatment, and that's what I did. In a total, I'm having a 24 patients that were actually having, instead of 12, were having 24 treatment sessions. The age was around 60. The duration is around 5 years. Responders were 8. The N was 8. Cardiovascular was 25. All of them, most of them were kind of cardiovascular risk factor. Again, almost half was diabetic, and that's how they were divided in group to severe, moderate, and mild. And it sounds normal because the more severe of those are probably were not responders to the shockwave treatment. After 12, they probably need more. And if you see here in this cartoon, you see that the baseline was IIF was IIFEF was 9. By the end of the first session, the 12 treatment, they didn't improve much. But after the second session, the result are almost 4 or 3.5, and which means that depends on the group. It means that they are getting better success. The question now, not academically, but practically, the question is how the patient is behaving after 6 treatment protocol and not the full 12. So Dr. Lin from Singapore published an article in his Singapore urology meeting in 2015, and he took 43 patients, and he gave them 6 treatment protocol session, include with daily Cialis or tadalafil, 5 milligram. The patient were around 62 years old, and you see that the follow-up after 1 month after the 6th treatment was around 80. Means that in some patients you can treat only 6 treatments. It was the same result with Professor Spivak from Moscow. He published it at the AU meeting in 2017, and he took 34 patients. He gave them 6 treatments. The difference was instead of asking them subjectively about the IAF, he took the Sham questionnaire. There was 34 patients, 11 were controlled, 23 under active, randomized clinical trial. The age was in Russia, but they are younger. Average ED was about 1 year. And you see that the Sham at the beginning, the baseline was 16, were improved to after 3 months of treatment 6 treatment to 22 point, which is statistically significant. The last question, and according to my opinion, the most important one is what's the patient of radical prostatectomy do? I took 29 patients. Small part of them were pilot, and the rest were randomized clinical trial. I was asked by Professor Wadi when he retired to stop the research, so that's why I'm having so only 29 patients. And the patient that we took, we took the patient that there were at least 1 year after radical prostatectomy. It was open radical prostatectomy. They are all severe at the ED at the baseline. And surprisingly, the 1/3 of them, almost 9 patients, were improved. I know that it's a small group, but those who were not improved at the first 12, I gave them another 12, and 3 out of those 4 were improved significantly with IIFEF more than 5 points, and the EHS was over PD, number 3 with PD5. And as I not mentioned at the beginning, Shockwave treatment has no side effect at all. Over, let's say, 4,000 patients in already 12 years. So now we ask ourselves, what's the different device with a different protocol? There is no large publication beside the ED1000 of Medispec, because I did most of the research in this field, and the others company they are not following us. And but Christo, the professor from Greece, did use Dornier, and you see in this slide that if we take the SES, the 6th treatment protocol about the 9,000 shocks, and the success rate is 5.4 change in IIF, and it became 7.4 in after 12. But if you calculate the success of IIF for each IIF change, how many shocks you need, if we take the 6 as 100%, you see that the 12 is around 70%. But if you take the Dornier, the 6, the 12, and the 18 treatment, which is 90,000 shocks, which is around the IF change as the 12 of Medispec, you see that the value is getting less than 15%. So if the 6 is 100 and 12 is 70, around 70% success, the 1200 is 13%. It's a correlation that the only machinery or system that they did a test to evaluate between the 2 different technology. Medispec is using mechanic system, and this is electromagnetic. So that's different. The electromechanic, the Medispec is the depth of the pressure is 140 millimeter, and the Dornier, the electromagnetic, is only 18 millimeter. So probably this is the big difference of the successful in giving patient shocks as a treatment. So who are the potential patients to treat and to get around 68–70% success rate? First of all, there are patients who do not have any erectile response. There are years without any vaginal penetration capability, which they are probably it's useless to treat. If they are pure neurogenic and not vasculogenic, like multiple sclerosis, spinal cord injury, probably they will not have any response. If there are no responses, neither to PD5 or even non-responses to injection, probably they will have very low, even if any, success. And of course, patients who are not compliant to the session. So the majority Patients who are responders to PD5 would like to be able to perform sex without PD5. Those who are non-responders anymore would like to be expected to become again responders to PD5, which is a one step back. So you see it as a protocol, as a line, a medication, hormone, and ED therapy is still non-invasive line, as well as vacuum pump. Injection and implant is invasive. So it's not the first line, it's the second or the third line of treatment of erectile dysfunction. So what's the advantage of the shockwave therapy? It's very low, if any, side effect. Sex life is more spontaneously because you try to cure the patient and not only the symptoms. And according to our 2 years follow-up, it's still working after at least 60% after 2 years. As a final remark, I would like to suggest those are the patients that I accept to shockwave therapy. If they are smoker, if they are diabetic, if they are obesity, if they're having hypertension or metabolic for any other reason, if they are medication treatment, if they are PD5 responders, it's very easy. They are very light, and probably they will benefit more. And if they are non-responders, but at least having some certain of erection response, we can be able to bring them back to be responsive to PD5. So as a take-home message, first of all, it's a non-invasive method, no side effect whatsoever. All over the world, I think around over 50,000 patients. It's able to take the place of oral medication, at least in those who are responders to PD5. It's able to reserve PD5 non-responders to be responders again. And using PD5 daily, 5 milligrams, it may increase efficacy, and most patients will benefit from 6 treatment protocols as well as 12. Thank you. Question?
Thank you so much. That was amazing. Very insightful. We do have some questions, but as there is a 20-second delay, so let me just remind all providers, if you have questions, to please post them in the comments section and I will read them out loud. So let's start off with our first question. Were any of the patients advised beforehand to make lifestyle changes? If not, how do you think the studies would have been impacted?
What do you mean life change? Taking medication or not taking medication?
I believe they mean like lose weight or stop smoking, all of that beforehand.
Well, in our institute as a tertiary referral center, most of the lifestyle changes are doing by GPs, and if they have failed, they send them to a urologist in the community urology, and when he is failing, he send the patient to me. Probably stop smoking, controlling the diabetics, changing medication, hypertension, let's say from ACE inhibitor to some other groups, losing weight, make some sports. It's obvious, but it's not the type of patient that I'm seeing regularly in my clinic. I see very severe, those who were responders to PD5 because PD5 is subscribed by GPs and cardiovascular patient, cardiologists, oncologists, when they are coming, when they are referred to me, they have severe problem. They are not responders anymore to PD-5, and post-radical prostatectomy patient. So I consider before going or starting with invasive treatment like injection or penile prosthesis implant, I sometimes suggest them, if they are vasculogenic, I offer them a shockwave treatment. That's the patient usually I see in my clinic.
Okay, got it. Thank you for clarifying. Our next question, one of our providers wants to know, those 60% of patients who were still satisfied after 2 years, did they receive just 12 treatments?
Yes.
Okay, awesome. And then our next question is, do you combine nitric oxide supplements along with Cialis?
Combine what?
Nitric oxide supplements along with Cialis?
No.
No. Is there any reason for that?
There's no good publication that's saying that nitric oxide is helpful, academically speaking.
Okay, sounds good. And then out of all of the factors you mentioned, like age, diabetes, etc., which one impacts severity the most in your opinion?
Diabetics, smoking, obesity, metabolic, hypertension, cardiovascular disease, cardiovascular risk factor, and medication.
Okay, great.
And all of them, for all of the patients, I check testosterone, prolactin, and thyroid TSH.
Okay, so you do a testosterone test beforehand?
Yes, of course.
Okay, great. Okay, and then as a last call for questions from our providers, I do have a question about a specific patient. So this provider has a patient, a 44-year-old male who's a type 2 diabetic. He reports no improvement in his ED with PD-5 inhibitors, and he's coming in for a consult. I want to make sure I'm realistic in the results he can expect.
Okay, I checked, 55-60% of my patient, of those almost 700 of Shockwave in research were diabetic. I checked the hemoglobin A1C. If it's higher than, let's say, 8.59, the success rate is about 50%. If it's less, it's a 68-70% success. I usually can offer them six treatment protocol, and after the 3 weeks of interval, I follow up them with the IIF, EF, and EHS, and if they're having some change, and usually they're having 3 or 4 sentences that repeat themselves. Something has happened, something has changed. Suddenly I have, for 10 years, I didn't have any morning erection, something like that. My penis is more vital and so on. So I continue with the other 6. If they don't respond, or if they are longer, then don't have any sexual activity around 7-8 years, I move them to injection or something else.
Okay, sounds good. Thank you. And then the last question that I could see that we have, and again, a lot of providers log on and watch this after their day is over. So providers, if you are watching this after we've wrapped live, please post your comments in the comment section and I will make sure to send them over to the MediSpec team. But our last question is, do you use any BLT cream or numbing agent?
No.
No. And do you not find that it's necessary, or does anybody complain?
No muse, no. And it's not the guideline, at least not in the European guidelines. The guidelines said that you treat them with a PD-5 inhibitor first line. You shockwaves with or without PD-5, vacuum device, and then you move them to injection and prostate. I have to emphasize that the patient is looking for a result. It doesn't matter what's the point of which line he is on. He wants some to have an erection, and he wants to function well. So Shockwave, I treat after radical prostatectomy. I treat a patient after bilateral hernioplasty, laparoscopic. I treat patient with medication of any kind. I treat hematologic patient with Clexane and Plavix, whatever. There is no side effect, and that's the main issue. There is no. It doesn't do any harm. The pressure is so low, and if it doesn't in 1/9 of breaking stone, it doesn't do in 36 millijoule or 900 bar, doesn't do any harm to the kidney. In 135, 150 bar to the penis, it doesn't do any effect. So, which is very important to mention that the Shockwave treatment is I never had any patient to recall to the Helsinki committee and said it was having even not the serious adverse event, even no normal adverse event.
No events at all.
No.
Yeah, that's super helpful. We've had mixed reviews within the provider group of, people getting BLT cream, and then a lot of people, like you said, say that it's just not even necessary. So that is really insightful information. And then one of our providers, and this will be the last question we're taking live, and we will forward you the questions after. But one of our providers says, I have a fair number of gentlemen with black backgrounds that cloud a simple vascular or even hormonal, neurological or psychological issue. What is your take on this, and how that impacts the treatment?
If it's not organic, if it's not vasculogenic, pure vasculogenic, I don't even suggest them to take shockwave therapy. No. Really? If it's a psychological, in 10 minutes interview and 5 papers of laboratory, you can experienced urologist can say if it's psychogenic or organic. If the erection is from one day to another, stop from one day to another, it's not organic. So I send them to psychologist, sexologist, and not treating them. If the decline is graduated, like the timetable is according to his diabetic decline, it's one thing. If he's taking medication, it's another. If he's a smoker, but it's not. The erection doesn't stop from one day to another. If it's from one day to another, it's not organic, and I don't even offer them shockwave. It's useless.
Mm-hmm. That's a very good and thorough explanation. We appreciate it. So if you want to get in touch with the Medispec team, find out more about the ED1000, or have any follow-up questions that you want to send directly to the Medispec team, you can email marketing@medispec.com, and I will post that link, that email address, in the comment section as well. So we thank you all for being here today, and thank you, Dr. Appel, and thank you, Medispec team. This was an awesome presentation, and we look forward to any follow-ups.
Thank you.
All right. Thank you. Have a great day.
Thank you. Bye-bye.